Hi, welcome back. I might as well say good morning because it is 4:30 in the morning and I'm sorry for the background orchestra of multiple birds that you might be able to hear through this recording. So here we are going to be managing pediatric cases who are presenting with COVID and looking at the different categories of illness, we'll quickly cover what to do in children. So if they're coming in with mild illness, where the common symptoms are rhinorrhea, cough with no breathing difficulty, gastrointestinal symptoms in some cases, the child can be managed at home with home isolation and symptomatic treatment. Children with underlying comorbid condition may also be managed at home if their regular physician has cleared it and there is definitely easy access to health facilities in case of deterioration. So if the child lives long distance away from a tertiary healthcare facility, please make sure that the child gets admitted to manage even the mild cases. So what to do with mild cases? For fever, you give paracetamol 10 to 15 milligrams per kilogram as a dose, and it could be repeated every 4 to 6 hours. For cough, if the child is old enough, you could recommend warm gargles or cough syrups is also recommended. Fluids and feeds should be maintained regularly, and good hydration and good nutrition is important in managing the early stages of COVID in mild patients. Antibiotics are definitely not indicated in the first few days of COVID, and there should be regular monitoring of the child and regular consultation or communication through the phone with the healthcare workers or doctor. If there are any danger signs, it should be reported early and the child should be taken to a hospital. What are the danger signs? So persistent fever beyond 5 days, increasing cough, difficulty in breathing, the child is getting more and more tired, or another danger sign is the child is getting drowsy. If you notice any cyanosis or if the child is complaining of chest pain, these should alert you in taking the child to a hospital as soon as possible. Moderate illness. Now here we're going to look at the respiratory rate, and this is only for clinicians. So please don't ask parents or other carers to be monitoring the respiratory rate of children. It is difficult as it is in adults, and in children, because of the higher numbers, it becomes even more difficult for an untrained person. So if you have to monitor, please send in a healthcare provider to their home. But these children with moderate illness, I'm assuming that they are present in a hospital where they should be ideally admitted with nurses and doctors reviewing their condition. So let's look into their respiratory rate. If a child is less than 2 months old, a respiratory rate of more than 60 per minute is not ideal. And if it is 2 to 12-month-old child, RR of more than 50, 1 to 5-year-old child more than 40, and if the child is above 5 years of age, respiratory rate more than 30, like we say in adult, should indicate that the child is having moderate COVID and they have pneumonia, but it is not extended beyond the margins of the lung and there is no respiratory failure. So going back into the slide, if you look at it, under 2 months, 2 to 12 months, 1 to 5 years and over 5 years as categories, and then looking at respiratory rate of more than 60, 50, 40 and 30. So managing a patient with moderate illness, they should obviously be admitted in a dedicated COVID health center with oxygen nurses and doctors. They should be monitored regularly and their fluid as well as electrolyte balance should be maintained. For fever, the child could be given paracetamol and amoxicillin to be prescribed if you suspect a bacterial infection. If the saturation is below 94%, please start oxygen and add steroids only if there is rapid progression of the illness. Severe illness is defined as severe pneumonia, ARDS, sepsis, septic shock, or multi-organ dysfunction syndrome. So in this, the common symptoms that you're looking for is a child with pneumonia and cyanosis or saturation below 90%, increased respiratory efforts and signs like grunting and severe retraction, lethargy or drowsiness, significant periods of time when the child is sleeping, or if the child is having a seizure, we should be alerted that the child is having a severe illness. Investigations recommended are complete blood count, liver function tests, renal function tests, and a chest X-ray to look at the extent of lung involvement. In severe illness, please admit the patient to a tertiary level hospital, so a dedicated COVID hospital with intensive care unit specified for children. You should be assessing the patient for thrombosis, hemophagocytic lymphohistiocytosis, which is an aggressive life-threatening syndrome of excess immune activation, which leads to multi-organ failure. So again, something to be managed fairly early. These children should be definitely started on steroids of 0.15 milligram per kilogram per dose to a maximum of 6 milligram twice a day for 5 to 14 days. And the duration, so we're looking for a short course of treatment, and the duration is depending on the clinical response. Empirical antimicrobials could be started given there is pneumonia, and you can wait for the culture to look at how to modulate and moderate it. Oxygen therapy from non-rebreathing bag, mask to high flow nasal cannula with humidified oxygen, and a trial of non-invasive ventilation if the other two are not working. The target saturation should be more than 94%, and once stable we should be going for a saturation more than 90%. So unlike adult, the children can be maintained at a lower saturation which is above 90% with oxygen support. Consider awake proning position. As we discussed before in the adult category, this has got significant evidence. So in older children where you can manage it, get them to be proning every 1 to 2 hours in different positions when they're awake. Fluid therapy, like in adults again, should be restrictive. We are looking for euvolemia, and we should be providing organ support if organs are involved, like renal replacement therapy. What do you do in ARDS? So in mild ARDS, high flow nasal oxygen or a trial of NIV. In severe ARDS, you'll have to go in for mechanical ventilation. Because it is a child with lower tidal volumes, please be aware of the fact that you're dealing with a smaller lung volume. So go for 6 milligram per kilogram as your guide for setting tidal volume. Go for a high PEEP like in adults. And this is a condition where you will be using cuffed endotracheal tube. Fluid should be managed in a restrictive way because of risk of renal involvement. Child should be sedated. And if there is poor response to initial mechanical ventilation, kindly consider prone ventilation. Management of shock in COVID in children. So in case of septic shock, you can give a crystalloid bolus administration in a hypotensive patient of 10 to 20 mils per kilogram over a 30 to 60 minute duration. I repeat, in a hypotensive patient, not in a normotensive patient. Be careful while administering fluid so that myocardial dysfunction, if suspected, is not made worse. Early inotropic support with monitoring for fluid overloading is very important if the patient is in sepsis. So this is true for any sepsis, but given there are so many other things that could go wrong in a COVID patient, please consider early inotropic support. So I hope that has been a sort of quick update on how to manage pediatric patients with mild, moderate or severe COVID. So one thing which was not mentioned in the slides is the fact that regular communication and taking the parents into confidence and using them in smaller children is vital in helping the children recover. So regular updates to the parents for older children in cases where they can't be coming in to see the child regularly. And in younger children, if possible, keeping the parents with the child and managing the child with the support of the parents in mild, moderate and early severe cases will be beneficial. If the child is intubated, then it will be difficult to get the parents in regularly. But even in those cases, please make sure that you're communicating regularly with the parents about the updates on the progression of the treatment and the condition of the patient. Also be aware that when these children are discharged, they will still need significant support at home, including respiratory physiotherapy, maybe even counseling. And consider these options as you are considering discharge of a patient who has been in intensive care unit for longer durations of time. Hope this clarifies the questions you might have had about managing patients who are of a younger age group presenting with COVID. And if the predictions are true, sadly, a lot of us who are not used to managing children might have to get involved in managing these patients, as the numbers that is expected to hit us are going to be pretty high. Hope it never comes true, but if it is turning out to be true, I'm sure that you will be confident and good clinicians in managing these children. Thank you so much.